My name is Jael Julie Okuku from Haki Network in Kenya. I am here to share how we integrate resilience-based geriatric HIV care. Ours is not only a research program, it's a presentation on resilience, life of people, and healthcare system change. 50% of people living with HIV globally are 50 years or more. Older adults with HIV face multimorbidity, frailty, depression. Kenya Aging and HIV intersection is under-researched and underfunded. That is how we came up with a response. And in this response, we made a network of intervention. Initially, we made it KAHIN, Kenya Aging HIV Intervention Network. But because Kenya is so broad, we narrowed it down to Nairobi. And that is how we came by with NAHIN. In NAHIN, we incorporated 7 comprehensive care clinics in Langata. We incorporated community health promoters, peer leaders, Kibera and Langata sub-counties. We integrated World Health Organization, ICOPE, resilience screening, peer support program. This is the flow of how we came about with NAHIN. We had to train healthcare providers in geriatric NCD care. Then we embedded resilience and depression screening. And the flow of this training was screening, peer groups. Because the peer groups were so wide, we divided people into mini groups. And in mini groups, we got to referrals. And referrals we monitored. Then we had peer-led support groups and referral pathways to physiotherapy, nutrition, and mental health. Then we went into modifying the data systems for aging indicators. In our findings, the key results were 58% of the care recipients had 2 or more comorbidities, 22% frailty, 31% functional deficits, 33% with low resilience. We linked to peer groups. Depression screening went up from 14% to 65%. ART adherence self-report rose to 19%. This is a graph that shows how we worked. You look at 23% with low resilience, 40% had 2 or more comorbidities, 15% had frailty, and 22% had functional deficits. These low resilience were linked to peer groups. After intervention, adherence went up to 19% through self-confessed, and this self-confessed through peer groups into the mini groups. They shared, and adherence rose to 19%. There was also this depressional screening that rose because initially they were not in groups and they would not share. But after putting them in groups, they had to share. The number of patients, the number of care recipients that we had were 360. And that is how we came about with this graph. So it was community-led. We had a program for the people, with the people. And the people were community health providers, healthcare providers. we had peer champions and lived experiences. Then we had flexible task shifting. We could refer easily because we had community health volunteers, we had peer champions, we had healthcare providers, and we also had mentorship and feedback loops. And that is how we shared tasks flexibly. We also had our shares of challenges. The challenges that we had were healthcare provider turnout, because there was a special training on geriatric care for healthcare providers. You would find that the group that turned out the first time is not the group that would turn out the next time. So we had to train again and go about training again and again. This was a big challenge unto us. Also, the healthcare team that came had limited geriatric literacy. Geriatric simply means elderly. So they had geriatric, there wasn't enough geriatric literacy in our training of healthcare providers program. So we had to incorporate Haki and Lean on Me Foundation to bring out the training, and the burden was so heavy. That is why, because it was a pilot project, we narrowed it down to Nairobi, and we did the 7 comprehensive care clinics. And also there was one of our challenges, there was inconsistent NCD medication supply. These people who had 2 or more multi-morbidities had at some point no medication, hypertension medication, diabetic medication was so limited. They were sometimes not available. So we had the turnover rate was low for the healthcare providers, literacy for geriatric healthcare, and medicine supply. So whatever we got, resilience screening is still feasible and acceptable. Multi-sectoral collaboration like we did is essential. You have to incorporate the peer champions, the healthcare providers. You also incorporate health promoters and peer champions to get a feasible and acceptable resilience-based geriatric care. There was also peer group, reduce isolation, and improve adherence. As we looked at the pie chart, we saw adherence rose by 19%. And as adherence rose by 19%, they shared it in mini groups. And in mini groups, there were champions of resilience in this program. And through their help and their counseling and their intervention, the resilience rose up by 19%. There should be EMR aging indicators. We find that in our country, the EMRs don't track aging indicators. The program, the treatment or the intervention they gave when a person was 20 years is the intervention they are giving when this person is 50+ years. So EMRs must track aging indicators to find out the age, how this patient is, how this care recipient is aging, and to track and find. That is how we can find a feasible, acceptable, resilience-based geriatric care. So we have, in resilience-centered geriatric HIV care, we find that it's achievable, even in low-resource settings, like as we work in Kibera and Langata sub-counties. Those are so low-resource setting environments. But through this system, resilience-centered geriatric HIV care made adherence to rise. And there was an intervention in place for the care recipients of age. So our next step, we want to scale NAHIN nationally. It was Kain initially, but we narrowed it down to Nairobi. So we can take it back to Kenya, Aging, HIV, Intervention Network. We can take it back to Kenya, because when we cover a bigger environment, when we bring everybody on board, even the government of our government on board, then we can achieve the goals that NAHIN has achieved. We want also to integrate HIV and NCD guidelines and secure sustainable financing. For more information, you can contact Ms. Jael Julie Okuku of Haki Group Nairobi through these numbers. I also have an email, and you can contact me through this email. We also have our geographical coverage area, that is Langata and Kibra for NAHIN. Otherwise, I'm very grateful to be in this forum. I'm so happy to share out on how we practiced resilience-based geriatric HIV care. And indeed, it is achievable. When we incorporate all stakeholders, then we can come out with a way of helping geriatric care recipients. Thank you.